everybody. Thanks again for coming this morning in our March cabin meeting. My name is Jim Podleski, Director of Alumni Relations, and before we get started, I think we should start with a prayer, and then Mary is our mother. Let's say a Hail Mary, in the name of the Father, Son, Holy Spirit, amen. Hail Mary, full of grace, the Lord is with thee. Blessed art thou amongst women, blessed is the fruit of thy womb, Jesus. Holy Mary, Mother of God, pray for our sinners, now and at the hour of death, amen. In the name of the Father, Son, Holy Spirit, amen. Good morning again. I think we'll have a very interesting discussion this morning on today's healthcare. Our moderator this morning is Ted Rizika, class of 1980. He's the head of Rizika Group Services, a financial group services company. He is on the state board for financial services and also the board in St. Louis. Without further ado, we call him Teddy Ballgame because he's moving 100 miles an hour. Ted Rizika.
Actually, I always thought Teddy Ballgame was because of my basketball prowess, and I found that that was not the case. Actually, I'm going to start, before I introduce the three panelists, I'm going to start with this. This program started about 2 years ago with Craig Plubiak and I having a discussion at Starbucks, and Father Ralph was nice enough to agree to do the Chaminade. I think we're doing 2 years now. And so what I'm going to do is start with this first. I'm going to have you guys fill out this real quick, if you don't mind. For this to be successful, it's going to take you to help us out on what our future programs are going to look like. So let me hand these out real quick. Craig, you want to help me take half these, take the right room and out.
Ted, you're not going to try to sell them?
No. And I have a bunch of pens over here. So basically, this is quick. I want to see in moving forward as far as events. So if you could fill that out real quick, write that out. We really need your input.
You know the answer to one? What I like about today's presentation?
What's that?
I have to tell you what I like about today's presentation.
Yes, you can. Ray, my cousin Ray, of course, said one of the questions is, what's your input about today's presentation? Well, hopefully it's going to be positive. I'm an optimist. So as you guys are filling that out, I'm actually going to begin. So, by the way, you cannot, so please continue to fill those out. We really need your input. You can't pick up a newspaper without reading about healthcare reform. And I'm just going to read a couple headlines here real quick. So, how to bring the price of healthcare into the open market. It talks about transparency. Here's January of this year. It says small business ACA checklist. It talks about all the changes about small businesses. Here's a great article in the Wall Street Journal. You guys should all read this. Who are the winners and losers? By the way, WellPoint said they're going to lose $100 million, by the way. Everybody thinks, oh yeah, the insurance company's got it. So it's a great article on that. I got a little trivia. Does anybody know, and anybody like Ryan can't answer this, Bill and Ray, does anybody know what day and year they signed the Affordable Care Act? Day and year. Take a guess. 4 years ago, that's correct. Okay, what was the day? What was the month? March 23rd. March 23rd. Who said that? There you go, March 23rd. There you go. All right, give me a round of applause. Okay. Now, this was in today's paper. Here's another trivia. Okay, this is in the Wall Street Journal. How many times was the Affordable Care Act delayed? How many times? Does anybody know? 20 somebody said, nope, that's incorrect. Anybody else? How many times? Take a guess. Throw some numbers out. 5, someone says no. How about 38? So Wall Street Journal, it says Obamacare delayed number 38 times. So there you go. Here's a great article, another one in USA Today, finding consensus on how to improve the Affordable Care Act. So, by the way, I know two of these gentlemen fairly well. I know Joe Battaglia and I consider us colleagues. Joe graduated from Chaminade what year? 98. And I know he went on to Boston College. You're with Doug Flutie, right? You're on the same team? No, anyways. And then, so he works for Arch Brokerage, and his father's here. His father can raise his hand. Joe Senior's over here. They run a great organization. Arch Brokerage in South County. And the other gentleman, Lou Rodder, whether he likes it or not, him and I were in a accounting class together. And Lou thinks because where he is today, because of me, I coached him on accounting. He actually was the other way around. So I always was a little concerned on my tough classes. I always had a lot of juniors in my class. I was probably the only senior that took how smart I was. So anyways, and then this gentleman, I'm going to have him, I know you're a Fred, I know you're a doctor, and I'm going to have each of these kind of give them like a little 30-second blurb about what they do. And then I want to make sure you know this is kind of open forum. I have a few questions for him, but this is really an open discussion. So guys, why don't we start, Joe, with the left. Tell us a little bit more about yourself, and maybe what you think the future holds in healthcare. Is it, should we, are we gloom and doom? Is there some positive things out there that we can see in this environment?
Yeah, so my name is Joe Botanin, and I'm with Arch Brokerage. We're an insurance brokerage and mid-size, so there's about 10 of us, so not a one-man shop, not a large brokerage house. And we work with employers basically from 2 all the way up to a few thousand. And basically, we try to help people make educated decisions for their health insurance, which has become increasingly difficult in the last 4 years. I kind of joke with my wife, but in the past it was a very boring topic, and now when I show up to speak somewhere, people actually come because they want to know what's going on. And it's also constantly moving target, so daily almost we're getting updates that are moving the market, trying to change how this is being implemented. From a future of healthcare, to me this is kind of a healthcare round 1, healthcare reform round 1, and we're going to see 2.0 and 3.0 come down the road. The things that have worked are going to shake out, but the things that haven't worked are going to have to be reworked and moved along over the next couple of years. So 2014 for us was always the D-Day. That was the end of healthcare reform when everything, January 1, 2014 was when everything was going to be implemented and the world was going to change. We quickly realized this was the beginning of how things are going to start to change, and the rounds of evolution we'll see coming forward.
Good morning again. My name is Lou Rodder. I work for SSM Healthcare here in St. Louis, and what I do is I develop and negotiate the contracts with the insurance companies for our hospitals and employed physicians, and I also help run 22,000-member employee health plan. Those are my principal duties. When Ted asked what do I think is going to change in the healthcare landscape, really 2 things popped in my mind. Is that hospitals typically had not been customer service oriented. We had actually, whenever you went to pay a bill, you just sat and somebody just gave you a piece of paper, didn't give you any particular options on how to make the payment, etc. What we're realizing is that if we want to get the dollars that are due to us, and I think that everybody understands that people are having greater out-of-pocket expenses to them personally, that we have to work with the folks as opposed to just saying you owe us the money. And the second thing to remind you, and Joe, I like what you said about round 1. This is round 1 of healthcare reform. In that, the health systems do understand there's going to be limited dollars available for healthcare services going forward. So what we're gearing up for is certain protocols, policies, and procedures on how to deliver healthcare services on a consistent basis. So those are the 2 things that came to mind. Okay.
I'm Fred Rotnick, and I'm Estovere Gun Bad. Let me be a cautionary tale to all you students. I'm faculty at St. Louis U in Family and Community Medicine. My clinical work is as contracted medical director for corrections in St. Louis County. So I'm the doc at the jail and juvenile detention, and I won't call anybody out in the room. But I've been doing that for almost 14 years. My career has been taking care of uninsured, uninsurable, marginalized populations. I've gotten very involved in the last several years in the Regional Health Commission, the Integrated Health Network, organizations in here that focus on access to care and safety net services. I agree that this is round 1, and I think that's a great way to look at it. We need reform in our country. There's no question of that. There's a lot of problems with the ACA, and I'll admit to that. But things will get better after Missouri solidifies its spot as a laughing stock in the U.S. for the actions of the Congress and our representatives in Jeff City. We need to get over that, and that's probably as political as I'll get today. Again, I warned you, I'll still be gone bad, but the point is that we're in a bad state in our state. We're going to lose money, we are losing money, we are losing jobs because of the action of the legislature in Jeff City, and that's affecting the organizations at the table as well as the people I take care of. Thank you for having me.
Obviously, they didn't have the dress code of the hair. I don't know if you guys remember, couldn't touch the collar. That's a little different. Actually, you stole my idea. My next question was, what do you think Missouri legislator, is the government helping us, hurting us as far as health care? Joe, you want to address that as far as Medicaid expansion, transparency? You know, how is our local government and state government hurting or helping us?
You know, I think with I touched on the Medicaid expansion piece. That is maybe I'll talk about maybe a little broader scope than just Missouri legislation. You know, one of the big problems with the ACA is the way that it's been, you know, either kind of defunded or unimplemented. So if you have the whole piece of legislation as a whole, it's going to have its problems and its pluses. If you took the whole thing off the table, there's problems and pluses there. If you have it and you take apart key pieces, then it becomes unworkable. And the Medicaid is a real good example of that. You know, if you write a law that only people above the Medicaid threshold are eligible for a subsidy, and then you take away those people below that, you create a gap, which is what we're seeing in Missouri, where you have people that might fall just below a subsidy level and are not eligible for Medicaid here, and they're not eligible for a subsidy, which is really the margin where people need the insurance the most. So, you know, basically by the argument between the federal and the state, and I'm not saying one's right or one's wrong, but because they're not agreeing and they're breaking apart the way the law is written, you get people that are falling into a hole. So, you know, that to me is an issue.
Yeah, Medicaid reform, that's something that's top on SSM's agenda, that we want to see that happen, because we do have a lot of folks that come to our emergency rooms, that are major hospitals, that do not have any type of insurance, any type of funding whatsoever. And if they're uninsurable, they probably have a lot of dollars behind them to pay for the services that they're receiving. And I heard a statistic the other day that to qualify for Medicaid in the state of Missouri, you have to reach 19th percentile of the poverty level. And everybody above that, you know, they fall into that gap, which is quite a shame. And Fred, just as you were saying, it's a shame that our legislature can't get together to harmonize, to pass something. But my only question is, with all this Medicaid expansion, where are those dollars ultimately going to come from? The federal government is just going to print money, and I think it's going to eventually fall on our backs to pay for it. That's my biggest concern.
There's only one state that has a lower eligibility rate than Missouri for Medicaid. It's 19% of federal poverty level, not 119%, but 19%. That means that an individual who makes more than $10 a day is ineligible for Medicaid in Missouri. The only state lower is Louisiana, and that's because they got a special waiver, so they could be 17%. So that's our competition. In terms of the issues that are important to this group in particular, and part of the shifting around of funding that we're looking at is the fact that a lot of safety net services all over the country are funded through something called DISH funding, some of you might be familiar with, which is disproportionate share to hospitals, for hospitals who do a lot of, more than their share of safety net services, which are the ones you could imagine in St. Louis, generally along Highway 40. Christian, of course, is one of them too. But we look at the disproportionate share funding is drastically shifting this year and will be going away by 2017. What does that mean? That means that if we stay in the pattern we're in now, hospitals will close who are getting disproportionate share funding, like Christian. Barnes will not close. There's a metaphor of St. Forest Park Hospital being torn down, but rural hospitals will close in the state because this money is going away. Look up DISH funding and impact of the ACA. And the other thing, there is concern about where this money is going to come from. Medicaid has never defaulted. on any payment to any state since 1960s. Medicare has never defaulted to any state since it was put in the 1960s. So I agree that there's concern about where the money's going to come from, but part of that money's coming from these disproportionate share payments, and there's other money that'll be there as well. But the point is that I think that some legislators, particularly in Missouri, are saying, where's this money going to come from? Well, there's no precedent for Medicaid and Medicare. And this change in the ACA with the funding coverage expansion of Medicare, is nothing compared to implementing Medicare in the 1960s. And that's maintained so far solvency.
So let me also address, I don't know if you guys all know it, but in the state of Missouri, we're one of the states that decided not to set up an exchange. We, the federal government, because of money again. And I don't know if you guys are familiar with the Hancock Amendment. I'll let some of these guys discuss that. So I'm going to say, so we talked about Medicaid expansion. Let's talk about the exchange and the federal exchange. So let's go ahead and I just want to have you guys chime in as little or as much as you want on the federal exchange here in the state of Missouri. Joe, you want to start?
Sure. I don't think either. I'll probably spend more time on the federal exchange than anybody in the room, I would guess. But we probably enrolled a few hundred people through the exchange in the last couple months. And a lot of those were current clients that we had to switch off of an old plan, or people that were on a group plan that are going to individual plans, or people that just got referred that haven't had insurance in the past. So there is that contingency. And I'll tell you from a theory standpoint, when that works, it can be really pretty neat, pretty heartwarming. I've had people that have never had insurance that have come in and are able to get a great plan and pay very little premium or no premium. And some families, immigrant families, that are kind of amazed that they're able to come here and get that kind of coverage. And then we've also had people that it didn't work that well for. So from an implementation standpoint, and just from utilizing the federal exchange, it's pretty horrendous from a layout standpoint, and how the website works and how the functionality. So that was to have 4 years to implement an enrollment process, has not gone well. And there's days when it goes well, and there's days when they say, sorry, come back another day. So it's that's an issue. I don't think that would have been better if Missouri had done their own. I think that's you've seen some states where they've had great success building their own, some that haven't. To me, there's too big of an upfront cost to try to do that, to try to get it right. Where from a federal standpoint, I think they should have been able to do that. To me, if that site could be functioning, it could be a pretty easy way to enroll people.
I guess when I think of the exchange and how it affects health systems here in St. Louis and even throughout Missouri, the number one thing that keeps coming to mind, something I touched on earlier, is that the benefit design, the member out of pocket is huge for these exchanges. It's at a low point of $6,000 and sometimes up to $9,000 and $10,000, meaning that the first $6,000 comes out of somebody's house, out of their pocket before they even pay, before we get paid by the insurance company. And which has caused us to redesign our approach with our patients as they come to our hospital. So now we have bank loans we can get at the time of service that can pay for your services. So, it's something that we had to go through. We actually get discounts for people if they pay out of their own pocket right up front to incentivize them to get the dollars, because it's such a big part of the payment that we get for those patients that come through. And I have to say also, it's a shame that we are, in my humble opinion, that we're on a federal exchange and that we don't have our own exchange here in Missouri, because we're missing out on revenue here in Missouri. And I think also by having our own exchange, we could probably do some neat things that we wouldn't be able to do or weren't able to do with the federal exchange. So I think we're on the same page.
Oh, yeah, just for example with that, if Arkansas set up their own exchange, they got 11 million just to hire healthcare navigators to help people through these processes. Missouri, since we didn't, got 2 million. And we have far more population and such. But, again, we're getting our hands slapped for not taking what is being offered. But the other issue that I just wanted to reinforce too was calling the health exchange insurance is a world of difference from what our insurance is. The deductible, the $6,000 deductible is huge. Basically what a lot of the, you talk about the bronze, silver, gold, platinum plans, kind of like we all had at one point in our jobs. Now we should just have one as well. It's not insurance in the sense that you've got a $25 copay and then you get hospitalized and $250 out of your pocket. It's more of this idea of catastrophic coverage. So it's a good thing. It needs to get a lot better, but it's not the same thing as what we call insurance. Something positive, because I do have some positive things, in the area that we have trialed and is going on now for the third year is Gateway to Better Health, which is a program that the Regional Health Commission is a fiscal agent for. It's been a program that we've worked with organizations like SSM, Mercy, St. Louis Shoe Barnes, to provide coverage for people in that 19% of poverty gap to now 100% of federal poverty, where it's not exactly insurance, but it's a coverage model that allows these people to get access to care for primary care. It's a model that has been picked up and recognized by the federal government of responsible ways of putting together an exchange or benefits, at least for primary care. It doesn't cover hospitalizations. People in Gateway, if they have to be hospitalized, they have to work through their payment plan with the hospital service, but at least it's looking at primary care and looking at medication management for this at-risk population, and hopefully we'll be able to provide information to the federal government about best practices about what we've seen working in the last years.
I just want to add one comment though on the plans on the exchange. That's something that I think is a shock that's coming. So the plans on the exchange have to fit these gold, bronze, silver, gold, platinum models, which are essentially actuarial values of 60, 70, 80, or 90%. And the plans don't have to be in between those. They have to be exactly those numbers, which means that the individual plans sold off the exchange also have to fit those same models. And the small group market plans starting when they renew after this year will also fit those models. So if you're on an individual plan on or off the exchange, if you're on a small group plan, you'll also have those same type of out-of-pocket expenses. So I think it's not just this exchange population, it's going to be across the board. You're going to see it more out-of-pocket going forward. I think that's a big reality.
I'm going to open it up to questions. Ryan, go ahead.
Fred, one thing I've never quite understood is they talk about Medicaid expansion and it costing jobs or creating jobs. If we haven't had it yet, why is, for example, Medicaid is the same rules we have now in Missouri? Why is it going to cost jobs now when it didn't cost jobs in the past?
Yeah. Well, part of it is the decreasing amount of disproportionate share funding that we talked about. Hospitals are already feeling the impact of that in terms of compensation. That's why just in October of last year, I know Barnes laid off over 200 employees for the first time in their 20 years history. SSN across the state was over 600 jobs, I believe. The funding is already diminishing because part of the ACA has gone into effect to start decreasing those disproportionate share funding. Where that funding is going to is the states that are participating in Medicaid expansion. So, not that we should hate Arkansas and Iowa and Illinois and Kentucky, but those 4 states that surround us are getting our federal dollars and will continue to get our federal dollars because we're not accepting them as part of expanding. And what that would change too if we accepted Medicaid expansion is we would go from 19% of poverty level to 133%. So our eligibility would automatically go up to that for Missouri residents for Medicaid. But the reason why the job loss issue is because funding shifts have already started happening in terms of money coming back from the federal government to the state.
Do you guys want to address the Hancock Amendment? You familiar with the Hancock Amendment? The Hancock Amendment basically says that we have to balance the budget every year. So there's where the other side of what Fred's saying is that, hey, you know what, there's like $1 billion a year. Because I've been to D.C. and I've been to Jeff City. And I've talked to, on both sides, and the people who are against, because there's some great things for, so I was like, man, why wouldn't you want $1 billion a year for 3 years? And they said, because we have to balance the budget. Remember, the federal government doesn't balance, they haven't balanced the budget in years. We do. So there's the big pushback. You talk to any legislator and say that's our concern, is because we are now going, and I've been to meetings at hospitals, that we're already in a partnership, but this would be a deeper partnership with the federal government. And so because we have to balance the budget, sure, the first 3 years are free, but after that, we pick up a percentage, I think it's 10%. 10%. Yeah, we pick up 10%, and that's what they're worried about. And so I've talked to, here's a guy who's going to, he's John Deal, who's going to be the head guy in our state legislature next year. He said the easy thing is to take the money today. And so he's looking long term. So I've been there and I've asked those questions just like you have, because I'm still trying to understand it. So, but again, if anybody asks, that's it. That's the reason why legislators say, because of the Hancock Amendment. Anybody else on questions? Questions? Go ahead.
You guys talked about this being phase one. How do you see it going forward? When should we expect phase two or phase three, or how do you see this playing out if possible?
I don't know if there's particularly a timeline on it, and so I think there's various aspects of events that are happening right now. So I was talking about the self-pay. So we will understand in about a year from now how that really is going to affect the healthcare industry and how we adjust to it so that we can continue to survive day to day. Other examples are what I was speaking to earlier, is that as we implement healthcare policies, procedures, standards, that those will become the norms rather than people practicing medicine differently. So there'll be more consistency, and hopefully with more consistency there'll be better outcomes. I think it's just going to be a variety of things that will allow that no matter what comes out.
Just for me, from an overall standpoint, basically healthcare reform is, impacts on the provider side, but really on the insurance side, who is paying the tab for care? Whether that's the state, the federal government, the individual, the employer, who's picking up the check? But in my opinion, it's still an all-you-can-eat buffet. There's still people going out and you get as much care as you want, really, and you don't know what it costs. So there's never any cost tied to it. So the next phase to me has to include some transparency, so that when I want to go get a knee replacement or knee surgery, I find out what that different cost is and whether this one has better results than that one. And also I have an awareness of what my own healthcare cost is, because as anybody knows that gets their coverage through an employer, you probably don't know what that costs each month. And then you also don't know what the procedures are that the insurance company's paying for. So there's about 3 or 4 people involved in each transaction. So to me, that the cost is what it has to be addressed at some point. Because who picks up the check is one thing, but how big the check is, if it continues to grow as a part of our gross, domestic product or our personal budgets, or whatever scale you look at, if healthcare takes up a bigger chunk of that dollar, at some point that becomes unsustainable. And I think we're getting close.
And I completely agree with that. One of the weaknesses that we see so far in the ACA is that we haven't talked anything about cost. And then access is one issue, but cost is the other. And whoever's been in the hospital here or has had a family member knows about that $10 box of Kleenex, right? That $10 box of Kleenex is because hospitals cannot bill for nursing services, and they can't bill for ancillary service, a lot of them. So things get shifted around that make absolutely no sense. And then you have a bunch of prima donna physicians, of course those of us family doctors aren't like that, that are not practicing frugal health care, even though the Institute of Medicine suggests that. But another example of next steps that are going into effect right now that started this past year is hospitals being dinged for readmission rates. Okay, and you're starting to see some headlines about that, and I know we've all seen that. A very practical implication of that is all the safety net hospitals in the area, SLU, Barnes, Mary's, DePaul, Christian, all have gotten penalties. I don't know if Mary's has, but if they haven't, they will. DePaul has. Yeah, DePaul has. For people being readmitted too quickly after their discharge, okay? It doesn't take much thought to put in mind that when you're dealing with people, working with people who are not well-resourced, who don't have a high health literacy, who don't know necessarily how to prioritize their health care in the broad scheme of life, they're going to have challenges taking care of themselves when they're discharged from the hospital. God knows our family members have a hard time doing that. The federal government has not indexed the hospital readmission rates to socioeconomic factors. It has indexed them to diagnostic, what they're in there for, but not to what is the hospital serving in terms of demographics of its patient population. That's something they're just considering now in Washington, okay? All of the urban hospitals we talked about are going to continue to lose money on readmission when they're taking care of the sickest people with the fewest resources in the community until this gets re-indexed. That seems like a minor thing, but those are the kind of things that we're uncovering as we're moving forward in these reform issues. And again, that's not the same thing as insurance and such, but it impacts all of us because right now these costs get shifted. Private insurance, we're all paying for it.
Does anybody have any other questions? Go ahead. Steve, go ahead.
So, to the cost statement, why is it not transparent? And also, if I do get a knee replacement, for example, how much does that cost change versus one hospital to the next?
I would say roughly double. I think probably for those kind of things. I mean, you can see a procedure from 10 to 20,000 in the same metro area.
Yeah. So why is it different? Is that your question?
And also, why is it not transparent right now?
Well, actually, it is transparent. If you have Anthem or United, you get online and you try to understand what would be your particular out-of-pocket. That being said, BJC has negotiated to their contracts that they won't be listed on those, unlike SSN, we're out there. But don't forget, when you look at those things, and remember who I work for, you know, look also, not only cost, but it's quality too. You get what you pay for. What drives the cost is really the negotiated rate. So when I'm at the table negotiating with Anthem, if I try to get a higher need price than our friends at Barnes, then that just comes out, or Mercy, then that just comes out of the website. So it's just a factor for the most part of the negotiated unit price.
In the system, you know, if your copay, let's say you have a great plan, one of those $100 deductible 100% plans, you don't care if it costs $10,000 or $20,000. You're paying $100 either way. So you know, go wherever you want. And after you hit your deductible, you might as well go get a few other things done too. You know, so there's incentives. And no offense to you, but I mean, on the provider side, there's incentives from a liability and from a profit standpoint to build more things. If you get an MRI, a CAT scan, and a few other things, each one of those is billed separately. You know, so those are all. And also, if you don't do it, and then I come back and sue you for not doing it, you know, so there's a liability incentive and a financial incentive, and the consumer is removed from that by several layers. You know, they're removed by the insurance company, they're removed by the employer. You know, so they're not paying the insurance premium, they're not paying the claims, and then, you know, a lot of times they're not paying the billed rate, they're paying the negotiated rate. So, you know, you have no idea what you're paying until maybe 3 months down the road when you get that final explanation of benefit, and then you find out what you actually have to pay. So there's just a large gap between the consumer and the endpoint.
Go ahead.
I've heard from another doctor that SSN is one of the hospitals that a lot of low-income people shifted to recently. And I was asking about Forest Park. Have you seen that at SSN? Have you seen basically people who are trained on the hospital? And I'm not saying that people are complaining, just saying from their standpoint, there's things.
Actually, I just saw something a few weeks ago, is that there's this, in Missouri, there's a group called HIDE, it's a hospital industrial data, something or other. And all the hospitals submit various information to them, and part of it is a paramedics. And when I say paramedics, you know, Medicare, commercial, self-pay. And actually, our self-pay was pretty much on par with everybody. But what we tend to have is we tend to have more Medicare patients than folks at Mercy who tend to have more commercial business. So the self-pay is pretty, it was more even than, actually I was surprised to see a number of people were surprised to see that.
You guys aren't having a disproportionate share
Of the self-pay? No, I don't think so. At least from what I've seen.
Go ahead.
Why are unions exempt from the law?
Because they can. Because they can. No, I don't know. I don't know what the answer is for that. Do you guys know?
You know, I mean, I think from a large point standpoint, you have several large employers that are exempt from certain parts of the law, you know, like your Walmarts, McDonald's, those kind of things. I mean, you have a lot of lobbying dollars that, you know, if this is going to cost me billions and I throw millions at it to solve it, that's a workable solution. You know, I think that's part of the answer anyway. You know, I don't think they're exempt from every piece of the law, but you know, there's definitely some special waivers out there for groups that don't want to follow the rules. So.
Yeah, and that's a good question because, as you know, there's been a lot of exemptions, and there's one going on right now with Hobby Lobby. You guys probably know, and supposed to be determined in June. But any other questions? Go ahead.
More of a comment on what we're
address that, by the way, here's a company, the largest CPA firm, Reuben Brown. Their whole firm has HSAs, the whole firm. So that tells you they're tax people, so they get it. So you're right, but unfortunately the law has pulled us away from that. And I think you guys mentioned there's a couple things. First of all, there is no incentive to be healthy in this law. No incentive. So that's a downside. So if you guys want to address anybody want to make any more comments?
I agree. I mean, I was probably doing 80 to 90% HSA offerings a year ago, and now that's going to drop off. You know, there's still some people that it fits for, but you know, it was made it more attractive. You know, with the offerings that are there. You know, instead of a $1,500 or $2,000 deductible, those HSAs are $6,300, which is unaffordable for most people. I agree.
Go ahead, Frank.
Joe, maybe you can address this because I've never understood. When the debate was going on, one of the cries was open up the insurance across state lines. And I don't understand how healthcare insurance, unlike any other insurance, you're boxed in by the state government. How does that happen?
Well, you know, in my understanding, I probably defer, but you know, for the most part, to me, it's a matter of contracts. You know, I mean, if you have an insurance company, if you want to buy a plan let's say you live in New York, and you're going to buy a plan in St. Louis, it's going to be cheaper because the cost of care in St. Louis is cheaper. So to me, the insurance company there's no way that they can insure you on a Missouri plan if you live in New York. And also, that insurance company doesn't have contracts with Mercy; they only have contracts with New York-based hospitals. And that's kind of my understanding of it. And then also, I mean, that's the first piece. But then the second piece is, you know, the state rules as far as what's allowed. You know, all insurance is typically regulated by each state. So there's a tremendous mess when you go to cross over from state to state. But I think a big part of it is just cost of care and contracts.
You guys want to address that at all?
I think it's correct structurally. What he's describing is that if somebody buys an Anthem exchange here in St. Louis, they would have to go to all the St. Louis hospitals. And their benefit design would cause them to go there. Because if you didn't go to one of the St. Louis hospitals, then you have to pay on that one.
Yeah.
But if you could buy, let's say every company offered a plan across the country, we'd all buy plans in northern Alaska that cost $100 a month. But none of your doctors would be in network, you know.
But wouldn't the market adjust to that, though? I mean, my insurance is still good in New York that I buy here in my auto and my life and everything else. So I guess I never understood the premise that if you open it up, the economics is going to even it out.
It is good. It is good there, but it's not at the same rate. You know, if you live in New York versus live here, you pay a different rate for your auto insurance. You know, you can go there. Just like with health insurance, you can go to New York and go to a hospital if you have an emergency. But you know, as far as what you pay is going to be based on your location, I think.
And the other thing that's kind of a bigger picture thing, but that's exactly the issues I always hear, is that people who are advocating now for universal health care are instead advocating for Medicare for all, because that's what Medicare does.
Yeah.
Medicare is a highly successful program. Nobody wants to take Medicare away. There's things that need to get tweaked, yes. But that's very close to universal health care, and that is scary.
I actually like that idea. I mean, Medicare for all, everyone could pick some kind of supplemental or advantage plan that works for them. We do a lot of that. My only downside to that, the only catch is we can't afford Medicare for the people over 65. So you know, adding it for the other, you know, 200 million is going to be an affordability issue.
Any other questions that you guys have? Go ahead, Don.
Guys, I graduated from Missouri State down in Springfield in '94. You know, went there from Chaminade to '90. Soon realized that the interest of the politicians in Missouri and outstate Missouri is much different, or viewed much different across the state as opposed to Kansas City. So, what can we do with our healthcare choices, how we vote, etc., to represent St. Louis and represent our interest in the bigger cities versus smaller town Missouri?
One, be very vocal. This healthcare law isn't the only thing that threatens our well-being. For one example, last year we had the House Bill 253, which would have cut state income tax. If we would have done that, all the mental health safety net in the entire state would have been falling apart, including closing Metropolitan Psychiatric Center on Delmar and closing all substance abuse areas and gutting the Department of Mental Health, what's left of it in the state. It also would be huge cuts to the school district. These are things that we're framing the safety net in the area, and I would love to blame all the rural legislators for these decisions. I do. But, but we have plenty of them in St. Louis County who are saying, my constituents want me to vote this way. And I would like to think that we're not all that callous to the common good of Missouri. So that idea of being explicit with your representative and talking with them. In terms of Medicare issues, the hospitals have chimed in, business organizations have chimed in, physicians group, providers group, health groups, Missouri Action for Social Work has chimed in. We have given the state legislature expert opinion on the issue of Medicaid, and they still choose not to expand it. So the idea is if you've got influence through your reps, or even if you don't cultivate that, that's extremely important because people are saying they're not hearing it. I don't know who they're not hearing it from. Because
I agree with you. They do need, I've been to Jeff City numbers, they need to hear from you. So, anybody, Chris, you had a question? Go ahead.
With the shift of healthcare costs going more and more, the burden being put on the patient, is there going to be more transparency, transparency? So before I have that knee surgery, I can know, hey, this may not be a good time for me to have it. There's going to be more technology, more communication to the patients. They know up front before they have the procedure what they're out of pocket.
Yeah, the answer to that question is yes, and I think it's going to happen twofold. One, with the insurance companies going to make their websites more expansive so that you can understand. And what we've been pushing for is with what they have is just the cost on there. So we're trying to get some quality statistics on there so that folks understand exactly what they're holding line. But then also on the hospital side, if you would call the hospital and say, I've got Anthem or United or Aetna, what would it cost me to have my knee replaced? We had historically not had that technology, and so now we're putting systems in place so that we can now answer that question. And so we are being more transparent than we historically have been on the price. And so that goes back to phase one, or step one, it's going to get better and better, the transparency as we go on.
And I'm going to add to that real quick. Just I think what we see, or I see in the market going forward, is an increased awareness and transparency on the insurance purchasing side. I mean, at a public exchange, if you're going to go out there and buy a policy and get a subsidy, you have to go through these, deductibles, copays, everything else, and figure out what you're going to buy. If you're going to go shop for an individual plan, the same is true. On the group status, you're going to start to see that as well, where you have private exchanges, where instead of you being offered policy A by your employer, or maybe two high-low, you're going to have 100 policies, and you're going to say the employer's going to give you a fixed, defined contribution, where they're going to say, here's $300 a month. You can spend it on the $300 plan that's got a real high deductible, or you can kick in $300 of your own and have a really rich plan. And so the consumer is going to be more involved in that process, like that's happened on retirement. We used to have pensions. Like how many people still have a pension at their employer? We have 401ks, and you're responsible for picking that investment selection and performance. And I think going forward, you're going to see healthcare follow that trend, where you're going to be responsible for picking the plan, and you can pick a plan. If you know you have that knee surgery coming up, you're going to pick a plan that has lower out-of-pocket costs, or maybe the hospital that you want in network. Relatively healthy young person, maybe you get by on a higher deductible plan and just go with catastrophic. So you're going to be, I think, everyone's going to have to be more involved from the purchase of insurance to the purchasing of healthcare.
And I'm going to address that too. So he mentioned about private exchanges. You guys already know the public exchange. That's the government set that up. So the future is, and there's a race here in St. Louis, a lot of brokers are trying to set up their own private exchange to bring companies into these private exchanges so you can do exactly that. So any other questions? I think we're going to, go ahead, one more, Joe, go ahead.
Just more to the hospital doctors. What do you think the quality of care, should we be more concerned about that in the future? I mean, there's like, some doctors probably aren't going to accept Medicare prices anymore, and they're maybe not treat Medicare patients.
Yeah,
I talk about the penalties in the hospitals for re-entry into the...
Because of that, you see concierge medicine maybe starting to blossom, and you just go to the doctor and say, hey doc, my foot's broke, 2 chickens and go, I mean, what can I do to
discharged from the hospital so that we can keep an eye on that patient so they're not readmitted. And so that's just enhanced medicine. The other thing, the other unintended consequence of the ACA is that it's causing us to have different conversations with the insurance companies that will in turn affect quality positively. So we have a contract with Coventry. They have a product called CareLink, and it's just SSM and one other health system here in St. Louis. And usually we get reimbursed on a per click. If somebody's in the hospital one day, we get X amount of dollars. But now, if we hit certain, if our physicians help us hit certain utilization statistics, such as days per thousand, meaning a ratio of how many days per thousand members, if we get it below a certain amount, we get an extra payment from the insurance company. If we hit certain quality metrics, such as blood pressure checks, we get extra dollars. So what's changing that's going to affect quality is the manner in which we're contracting with the insurance companies is different today than it was historically.
The other thing too is that we're in a huge generational change in terms of training physicians and other healthcare providers. Right now, there's a lot of pussy doctors out there, my age and older, who don't like the way things have changed. And just look at the electronic health record to get an example of that, okay? And I teach at SLU, so I speak from experience. Students are changing, the practice of medicine is moving much more towards team-based care, which is a good thing. We could argue all day about that. It's a good thing. We have people that are going to function on teams who grew up being educated on teams. You guys sitting back probably know that you guys we're not acculturated like we were to be our own little fiefdoms, to study on our own, to learn on our own. So there's huge changes there. So is going to be shifting to acknowledge team-based care, patient-centered medical homes, things along those lines. Things like evidence-based practice, which to somebody my age makes complete sense. You do things based on evidence, not because that's how somebody told you to do it. You look it up. Is a norm. Better care comes out from it. That is a new concept when I was in med school, evidence-based practice, and that wasn't 20 years ago. There's a lot of changes, and I think that the changes that are going to be happening are huge. And like we said, there's so many layers between what a patient or consumer sees and how things are reimbursed, but those things are all going to have to change over time to acknowledge the change in the way that medicine is practiced and will be practiced over the next generation.
So I'm going to wrap it up, but I got to tell you what one of the, this was a couple years ago, there were about 500 brokers, and this keynote speaker was a nationally known doctor, and someone asked a good question. This is 5 years ago, before the ACA. He said, if I could do one thing, just one thing, tell me what I can do to improve my health care. He said, stop coming in my office and acting like a child. He said, do your own. And that's the key, because you mentioned about consumer, that's what it comes down. It comes to taking responsibility. So I'm going to have Jim wrap it up. And by the way, if I can get those sheets for those things I had you guys fill out before.
Again, thanks guys for coming today. A couple of housekeeping matters. First of all, our next cabin meeting is going to be May 15th. It'll be a straight networking day. And you'll get more information about that as we get closer to that date. Also, on April the 24th, we host the annual Ethics in the Workplace Seminar / Career Day for our seniors. And if you would like to participate in that, I could have you in the morning session where we talk about, we do an ethics workshop with Frank and myself and our seniors, and then in the afternoon is more of a career day where the seniors are allowed to visit a couple different areas of work areas that they can visit and learn about. So if you're interested in that, let me know. You'll get more information about that as we get closer as well. And speaking of seniors, if I could have our 5 seniors come on back and come up here and introduce yourselves to the rest of the crowd. Come on. This is what networking is all about. And part of the mission of CABN is to eventually help out our younger guys in business, as well as all alumni, but especially our younger guys. So come on, guys. Why don't you introduce yourselves, where you think you can go to school, and what you might study next year?
I'm Grant Hollander. I'm going to Arizona State to study physical therapy. I'm Mike Thurston. I'm going to Mizzou to study accounting.
Oh, wow. Thomas Martin. Not sure where I'm going. I'm between business and pre-dental, I think.
Jack Bowser. I'm going to the University of Indiana. I'm going to major in finance and accounting.
I'm Grant Barron. I'll be attending the University of Chicago next year, and I'll be studying economics.
Thanks, guys. Thanks, guys. One more note, Craig Peruviak of our cabinet committee would like a couple of seconds to talk.
Thanks, students, for joining us today. Boy, what a great panel this morning, isn't it? I'm more confused now when I came in because there's so much information.
I've done my job then.
Yeah. Let's thank our panelists for coming. Thank you, guys.
Thank you. Outstanding. Just a couple quick comments. One is Time Magazine just recently on the cover had a story about the techies that saved Obamacare. And inside of it, the gist of it is that one of our graduates from this school, John Doerr in Silicon Valley, was the person the White House called and said, this technology program isn't working. Who can we talk to? How can we get this fixed? And there were 2 paragraphs in there talking about John Doerr and how he arranged it and brought the right tech team together to help them. We're hoping, we've been having conversations with John's assistant for the last 6 months about trying to get him Skyped in one of these days as an alumni for this program, which leads to the fact that I know there's been many conversations about the purpose of this group is really parochial. When we started, it was how can we benefit in terms of business relationships? And I can tell you point blank, my son Stephen and I have had some meetings with some folks as a result of this from the consulting standpoint. I'm on the board of a cyber counterintelligence company. I'm working with somebody as a result of this group, looking at rolling out a new company concept tied to the insurance world. It's 5 o'clock this morning. I was texting around the country because I'm involved with Kevin Haar, who's running Tapestry. It's a $35 million have been put into this gene testing big data company, and we're connecting with people around the world. In fact, one of our alumni classmates is a result of this group, working with Ray Razika, Troy Brennan, who's a senior executive at Caremark, has been connected into this whole thing. It's absolutely amazing from my parochial standpoint in the last 18 months what kind of cutting-edge activities we've been introduced to as a result of this group. So I'm suggesting you all keep it in mind, we're only meeting twice a semester, but to have a group like this up front sharing information, it's just totally up to you all if you want to benefit from it. But the idea again was, can this be an engine to help build our individual businesses and help build the community? Because what amazing resources as you hear these gentlemen speaking this morning again. Thank you so much.
It is a $25 gift certificate down to Grassi's.
All right. Do they let long hair men in there? Correct?
Oh, yeah. All right, guys, we're good. Appreciate it. Obviously, if you want to hang out and you have got time, feel free.
Good group one.
Yeah.
But I want to come back and get involved. I for this 100%. I think they're doing a great job. But I've been down since, I was here initially. So I put on there, getting up and around the things work. Yes, thanks. So if I can help you or come out of the meeting or whatever, it's just, for the last 30 months, I was miserable. I mean, I had a tough time, but now I'm 4.5 months out of the last replacement. I'm doing great. So I'm going to be, if I can, you need somebody to. Oh, yeah. And I'm available. I still work. I think I'm going to retire at the end of the year. All right, I was in the banking business.
Oh, just make this table.
With Chester Commerce Club. So I was with Commerce, I was with United Missouri, in my last 11 years, Citicorp. I ran I was a commercial lender. I was a guy that started a lot of businesses in town. And now, I'm a veterans rep for the VA. I take care of disabled veterans when they come in. Homeless, I try to help them overcome the barriers. So, next month, I'll be 5 years in with the state, 6 I just want to say you've done a great job putting this together, and I know you're the wheels behind the scene, and I thank you for that. But I'm gonna help you as my team. You know, well, you know what? Yeah, you know, like you said, so yeah, I have all the thank you for the good job that you've done, and I put all of this on my little card. And Jim knows me. I talk to Jim all the time, and on an if-needed basis. But now that I'm up and around and feel better, I just wanted to tell you that's why I'm back. Good. To see you. And this was a great one.
These guys are awesome. They were great. Thank you.
All right.
I know. And now I'm under trustee committee for this and she got me through, and my mom was trying to put that with another. She did not want to trust. It sounded like every day. Why I ended up here. I know. No, the